Placenta Praevia, Placenta Praevia Accreta, and Vasa Previa. Diagnosis and Management. Green Top Guideline number 27, January 2011. Background and Introduction. Placenta Praevia and Placenta Praevia Accreta. With the rising incidence of cesarean sections combined with increasing maternal age, the number of cases of Placenta Praevia and its complications, including Placenta Accreta, will continue to increase. Placenta Praevia exists when the placenta is inserted wholly or in part into the lower segment of the uterus. It is classified by ultrasound imaging according to what is relevant clinically. If the placenta lies over the internal cervical os, it is considered a major praevia. If the leading edge of the placenta is in the lower uterine segment but not covering the cervical os, minor or partial praevia exist. A morbidly adherent placenta includes Placenta Accreta, Increta, and Percreta as it penetrates through the decidua basalis into and then through the myometrium. Vasa Previa. Vasa Previa describes fetal vessels coursing through the membranes over the internal cervical os and below the fetal presenting part, unprotected by placental tissue or the umbilical cord. This can be secondary to abvelamentous cord insertion in a single or bilobe placenta or the Vasa Previa type 1, or from fetal vessels running between lobes of a placenta with one or more accessory lobes, or the Vasa Previa type 2. The reported incidence varies between 1 in 2,000 and 1 in 6,000 pregnancies. Unlike Placenta Praevia, Vasa Previa carries no major maternal risk, but it is associated with significant risk to the fetus. When the fetal membranes are ruptured, either spontaneously or artificially, the unprotected fetal vessels are at risk of disruption with consequent fetal hemorrhage. Vasa Previa therefore often presents with fresh vaginal bleeding at the time of membrane rupture and fetal heart rate abnormalities such as decelerations, bradycardia, a sinusoidal trace, or fetal demise. The mortality rate in this situation is around 60%, although significantly improved survival rates of up to 97% have been reported where the diagnosis has been made antenatally. More rarely, bleeding can occur in the absence of membrane rupture. Because the fetal blood volume is around 80 to 100 milliliters per kilograms, the loss of relatively small amounts of blood can have major implications for the fetus. Thus, rapid delivery and aggressive resuscitation, including the use of blood transfusion if required, are essential. Very rarely, fetal heart rate abnormalities in the absence of bleeding may be present secondary to compression of the fetal vessels by the fetal presenting part. Risk factors for Vasa Previa include placental anomalies such as bilobe placenta or succenturate lobes, where the fetal vessels run through the membranes joining the separate lobes together, a history of low-lying placenta in the second trimester, multiple pregnancy, and in vitro fertilization, where the incidence of Vasa Previa has been reported to be as high as 1 in 300. Disturb orientation of the blastocyst at implantation, vanishing embryos, and the increased frequency of placental morphological variations in vitro fertilization pregnancies have all been postulated as the reason for this association. Screening and diagnosis for Placenta Praevia or Accreta. Can we diagnose Placenta Praevia clinically? Clinical suspicion should be raised in all women with vaginal bleeding after 20 weeks of gestation. A high presenting part, an abnormal lie, and painless or provoked bleeding, irrespective of previous imaging results, are more suggestive of a low-lying placenta but may not be present, and the definitive diagnosis usually relies on ultrasound imaging. Should we screen for placental localization? Routine ultrasound scanning at 20 weeks of gestation should include placental localization. How should we image for placental localization? Transvaginal scans improve the accuracy of placental localization and are safe, so the suspected diagnosis of Placenta Praevia at 20 weeks of gestation by abdominal scan should be confirmed by transvaginal scan. In the second trimester, transvaginal sonography or TVS will reclassify 26 to 60% of cases where the abdominal scan diagnose a low-lying placenta, meaning fewer women will need follow-up. Which women need further imaging if the placenta is low at 20 weeks of gestation? All women require follow-up imaging if the placenta covers or overlaps the cervical os at 20 weeks of gestation. Women with a previous cesarean section require a higher index of suspicion as there are two problems to exclude: Placenta Praevia and Placenta Accreta. If the placenta lies anteriorly and reaches the cervical os at 20 weeks, a follow-up scan can help identify if it is implanted into the cesarean section scar. Placental apparent migration, owing to the development of the lower uterine segment, occurs during the second and third trimesters, but it is less likely to occur if the placenta is posterior or if there has been a previous cesarean section. The chance of persistence of the Placenta Praevia requiring abdominal delivery was 50% in women with a previous cesarean section, compared with 11% in those with no uterine scar. Significant migration to allow vaginal delivery is unlikely if the placenta substantially overlaps the internal os. Such migration is still possible, and therefore follow-up scanning should be arranged. When should further imaging occur? Women who bleed should be managed individually according to their needs. In cases of asymptomatic women with suspected minor previa, follow-up imaging can be left until 36 weeks of gestation. In cases with asymptomatic suspected major placenta previa or a question of placenta accreta, imaging should be performed at around 32 weeks of gestation to clarify the diagnosis and allow planning for third trimester management, further imaging, and delivery. Women with major placenta previa or placenta accreta are at high risk of preterm delivery and severe morbidity, and therefore, clarification of the diagnosis earlier than 36 weeks is beneficial. When the placenta has completely covered the cervix at the 20-week scan, making major placenta previa more likely, or if the placenta is anteriorly placed and reaching the os in a woman with a previous cesarean section, making placenta accreta more likely, earlier follow-up imaging is advised. Of those women in whom the placenta is still low at 32 weeks of gestation, the majority, 73%, will remain so at term, but 90% of major previas at this gestation will persist. Imaging at 32 weeks therefore seems timely in enabling a fairly definitive diagnosis to be made alongside a plan for further care, including follow-up imaging for possible accreta, counseling for delivery, and planning delivery. How can a morbidly adherent placenta be diagnosed? Women who have had a previous cesarean section, who also have either placenta previa or an anterior placenta underlying the old cesarean section scar at 32 weeks of gestation, are at increased risk of placenta accreta and should be managed if they have placenta accreta with appropriate preparations for surgery made. Antenatal sonographic imaging can be complemented by magnetic resonance imaging in equivocal cases to distinguish those women at special risk of placenta accreta. Antenatal imaging techniques that can help to raise the suspicion of a morbidly adherent placenta should be considered in any situation where any part of the placenta lies under the previous cesarean section scar, but the definitive diagnosis can be made only at surgery. These techniques include ultrasound and magnetic resonance imaging or MRI. Numerous ultrasound imaging techniques have been reported over the years, including grayscale, color, and/or three-dimensional power Doppler sonography. Three-dimensional power Doppler gives the best overall results when an isolated criterion is found. Table number 1. Diagnostic performance of different ultrasound modalities. Grayscale. Sensitivity 95%. Specificity 76%. Positive predictive value, 82%. And risk, 93. Color Doppler, sensitivity, 92%. Specificity, 68%. Positive predictive value, 76%. And risk, 89. Three-dimensional power Doppler, sensitivity 100%, specificity 85%, positive predictive value 88%, and risk 100. Ultrasound criteria for diagnosis were as follows. Grayscale. Loss of the retroplacental sonolucent zone, irregular retroplacental sonolucent zone, thinning or disruption of the hyperechoic serosa bladder interface, presence of focal exophytic masses invading the urinary bladder, and abnormal placental lacunae. Color Doppler. Diffuse or focal lacunar flow, vascular lakes with turbulent flow, peak systolic velocity over 15 centimeters per second, hypervascularity of serosa bladder interface, and markedly dilated vessels over peripheral subplacental zone. Three-dimensional power Doppler. Numerous coherent vessels involving the whole uterine serosa bladder junction, basal view, hypervascularity, lateral view, and inseparable cotyledonal and intervillous circulations, chaotic branching, Dethor vessels, lateral view. Ultrasound and MRI or magnetic resonance imaging have comparable sensitivity and specificity at detection, but magnetic resonance imaging was better at detecting that of infiltration in cases of placenta accreta. Many authors have therefore recommended magnetic resonance imaging for women in whom ultrasound findings are inconclusive. Antenatal management. Prevention and treatment of anemia during the antenatal period is recommended. Where should women with placenta previa be cared for in the late third trimester? Women with placenta previa in the third trimester should be counseled about the risk of preterm delivery and obstetric hemorrhage, and their care should be tailored to their individual needs. Any home-based care requires close proximity to the hospital, the constant presence of a companion, and full informed consent by the woman. There remains a paucity of evidence to guide place of care. Neither the likelihood of bleeding nor the need for rapid delivery was associated with the degree of previa. All women at risk of major antepartum hemorrhage should be encouraged to remain close to the hospital of confinement for the duration of the third trimester of pregnancy. If women are managed at home, they should be encouraged to ensure they have safety precautions in place, including having someone available to help them should the need arise, and particularly having ready access to the hospital. It should be made clear to any woman being managed at home that she should attend immediately she experiences any bleeding, contractions, or pain, including vague suprapubic period-like aches. Decisions regarding blood availability during inpatient antenatal care should be based on clinical factors relating to individual cases as well as on local blood bank services. Women with atypical antibodies form a particularly high risk group, and discussion in these cases should involve the local hematologist and blood bank. Is there a place for cervical cerclage in these women? The use of cervical cerclage to reduce bleeding and prolong pregnancy is not supported by sufficient evidence to recommend this practice outside of a clinical trial. Is there a place for tocolytics in women who bleed? Tocolysis for treatment of bleeding due to placenta previa may be useful in selected cases. However, beta mimetics were used in the studies to date, and as these are known to be associated with significant adverse effects, the agent and optimum regime are still to be determined. Further research is needed in this area. The etiology of bleeding in placenta previa is due to the dynamics of the development of the lower uterine segment, but may also be triggered by uterine activity. This has prompted obstetricians to try conservative aggressive management of placenta previa using tocolysis in this situation. Treatment was associated with prolongation of pregnancy and an increased birth weight. No adverse effects to mother or baby were shown, and particularly no increased risk of bleeding was found. Is there a place for the use of prophylactic tocolytics in women to prevent bleeding? Prophylactic terbutaline to prevent bleeding has not been found to benefit women with placenta previa. What precautions should be taken against venous thromboembolism for inpatients? Prolonged inpatient care can be associated with an increased risk of thromboembolism. Therefore, mobility should be encouraged together with the use of thromboembolic deterrent stockings and adequate hydration. Prophylactic anticoagulation in women at high risk of bleeding can be hazardous, and the decision to use it should be taken on an individual basis considering the risk factors for thromboembolism. Limiting anticoagulant thromboprophylaxis to those at high risk of thromboembolism seems reasonable. Preparations for delivery. Prior to delivery, all women with placenta previa and their partners should have a discussion regarding delivery, indications for blood transfusion, and hysterectomy should be reviewed, and any concerns, queries, or refusals of treatment should be dealt with effectively and documented clearly. In what situations can vaginal delivery be contemplated for women with a low-lying placenta? The mode of delivery should be based on clinical judgment supplemented by sonographic information. A woman with a placental edge less than 2 cm from the internal os in the third trimester is likely to need delivery by cesarean section, especially if the placenta is thick, but the evidence for this is poor and further research in this area is needed. As the lower uterine segment continues to develop beyond 36 weeks of gestation, there is a place for transvaginal scan if the fetal head is engaged prior to an otherwise planned cesarean section. Decisions regarding the mode of delivery take into account clinical factors as well as ultrasound findings and the woman's preferences, especially if the fetal head has entered the pelvis. Ultrasound can add to this information in terms of where the fetal head is relative to the leading edge of the placenta, and the thickness of the encroaching tongue of the placenta has been shown to influence outcome. The thicker the placenta, over 1 cm, the greater the likelihood of abdominal delivery. At what gestation should elective delivery occur? Elective delivery by cesarean section in asymptomatic women is not recommended before 38 weeks of gestation for Placenta Praevia or before 36 to 37 weeks of gestation for suspected Placenta Accreta. Placenta Praevia and Placenta Accreta are associated with preterm delivery, with 40% of women delivering before 38 plus 0 weeks of gestation. Individual characteristics should be considered, but with the planning needed for the especially high-risk cases suspected of having placenta accreta, plan delivery at around 36 to 37 weeks of gestation with corticosteroid cover is a reasonable compromise, while in those with uncomplicated placenta previa, delivery can be delayed until 38 to 39 completed weeks of gestation. What preparations should be made before surgery? Placenta previa without previous cesarean section carries a risk of massive obstetric hemorrhage and hysterectomy and should be carried out in a unit with a blood bank and facilities for high dependency care. The care bundle for suspected placenta accreta should be applied in all cases where there is a placenta previa and a previous cesarean section or an anterior placenta underlying the old cesarean scar. Care bundle for placenta previa accreta. 6 elements considered to be reflective of good care were as follows: consultant obstetrician plan and directly supervising delivery, consultant anesthetist planned and directly supervising anesthetic at delivery, blood and blood products available, multidisciplinary involvement in pre-op planning, discussion and consent includes possible interventions such as hysterectomy, leaving the placenta in place, cell salvage, and intervention radiology, and local availability of a level 2 critical care bed. The view regarding place of delivery is that women who decline blood products should be transferred to a center where cell salvage and interventional radiology are available. The unpredictable nature of this potentially high-risk surgery means that the need for a level 2 critical care bed should be confirmed before an elective procedure is embarked upon. What blood products are needed? Placenta Praevia. Blood should be readily available for the peripartum period, whether ready cross-match blood is required, and in what amount will depend on the clinical features of each individual case and the local blood bank services available. When women have atypical antibodies, direct communication with the local blood bank should enable specific plans to be made to match the individual circumstance. There is no evidence to support the use of autologous blood transfusion for placenta previa. Cell salvage may be considered in women at high risk of massive hemorrhage, and especially in women who would refuse donor blood. The Obstetric Anesthetists Association, or OAA, supports its use, as does the Royal College of Obstetricians and Gynecologists, which suggests it is appropriate when anticipated blood loss exceeds 1,500 milliliters. Suspected placenta accreta. Cross-match blood and blood products should be readily available in anticipation of massive hemorrhage. Where available, cell salvage should be considered, and if the woman refuses donor blood, it is recommended that she be transferred to a unit with a cell saver. When is interventional radiology indicated? Interventional radiology can be life-saving for the treatment of massive postpartum hemorrhage, and therefore, having this facility available locally is desirable. If a woman is suspected of having placenta accreta and she refuses donor blood, it is recommended that she be transferred to a unit with an interventional radiology service. The place of prophylactic catheter placement for balloon occlusion or in readiness for embolization if bleeding ensues requires further evaluation. Uterine artery embolization in cases of uncontrolled hemorrhage can be life-saving and uterus sparing and should be considered. The current Royal College of Obstetricians and Gynecologists' opinion is that further work is required to establish the risk and benefits of this technique as a prophylactic measure before it can be recommended. What anesthetic is most appropriate for delivery of the baby? The choice of anesthetic technique for cesarean sections for placenta previa and suspected placenta accreta must be made by the anesthetist conducting the procedure. There is insufficient evidence to support one technique over another. What should be included in the consent form for cesarean section? Any woman giving consent for cesarean section should understand the risk associated with cesarean section in general and the specific risk of placenta previa in terms of massive obstetric hemorrhage the need for blood transfusion, and the chance of hysterectomy. The risk of massive hemorrhage is approximately 12 times more likely with placenta previa. This should be explained together with the possibility of needing a blood transfusion. The risk of hysterectomy is also increased and rises when associated with previous cesarean section. Table number 2. Link between number of previous cesarean sections and risk of placenta accreta, placenta previa, and hysterectomy. Any woman with suspected placenta previa accreta should be reviewed by a consultant obstetrician in the antenatal period. The different risk and treatment options should have been discussed and a plan agreed, which should be reflected clearly in the consent form. This should include the anticipated skin and uterine incisions and whether conservative management of the placenta or proceeding straight to hysterectomy is preferred in the situation where accreta is confirmed at surgery. Additional possible interventions in the case of massive hemorrhage should also be discussed, including cell salvage and interventional radiology when available. The anticipation and planning of surgery for suspected placenta accreta enables logical and timely decisions to be made without the element of surprise and often without the urgency of massive hemorrhage. To mention and gain consent for the use of balloons, cell salvage, and interventional radiology is recommended and is much easier done before needed. What grade of obstetrician should attend? A junior doctor should not be left unsupervised when caring for these women, and a senior experienced obstetrician should be scrubbed in theater. As a minimum requirement during a planned procedure for placenta previa, a consultant obstetrician and anesthetist should be present within the delivery suite. When an emergency arises, consultant staff should be alerted and attend as soon as possible. Any women going to theater electively with suspected placenta previa accreta should be attended by a consultant obstetrician and anesthetist. If the delivery is unexpected, out-of-hours consultant staff should be alerted and attend as soon as possible. The most recent confidential inquiry into maternal and child health stresses the importance of a consultant-led multidisciplinary team at delivery in women at risk of placenta accreta. When hysterectomy is anticipated, consent should include that for hysterectomy and delivery, it should involve specialized multidisciplinary personnel and occur where there are facilities for high-volume blood transfusion and availability of other blood products. Surgery in the presence of placenta accreta, increta, and percreta. What surgical approach should be used for suspected placenta previa accreta? Surgeons delivering the baby by cesarean section in the presence of a suspected Placenta Praevia Accreta should consider opening the uterus at a site distant from the placenta and delivering the baby without disturbing the placenta in order to enable conservative management of the placenta or elective hysterectomy to be performed if the accreta is confirmed. Going straight through the placenta to achieve delivery is associated with more bleeding and a high chance of hysterectomy and should be avoided. Conservative management of placenta accreta when the woman is already bleeding is unlikely to be successful and risk wasting valuable time. The choice of skin and uterine incision needed to avoid the placenta will depend on the location of the placenta. A low transverse skin incision allows access to the lower half of the uterus and is reasonable if the upper margin of the anterior aspect of the placenta does not rise into the upper segment of the uterus. If, however, the placenta is anterior and extending towards the level of the umbilicus, a midline skin incision may be needed to allow for a high upper segment longitudinal uterine incision. It is therefore useful for the surgeon to perform an ultrasound scan before surgery to plot out the extent of placenta before starting. This is surgical logic and not evidence-based. What should be done if the placenta does not separate after delivery of the baby? The antenatal diagnosis and surgical avoidance of the placenta and its separation may be associated with reduced maternal morbidity. It allows for conservative management of the placenta, reducing the risk of hysterectomy and of bleeding if the placenta is indeed found to be adherent. If the placenta fails to separate with the usual measures, leaving it in place and closing, or leaving it in place, closing the uterus, and proceeding to a hysterectomy are both associated with less blood loss than trying to separate it. This approach of elective hysterectomy would be unacceptable to women desiring uterine preservation, and in such cases, leaving the placenta in place is another option. Attempting placental separation risks hysterectomy in up to 100% of cases and therefore is illogical. Complications of conservative management: persistence of heavy bleeding requiring hysterectomy, and infection may lead to sepsis. Evacuation of retained products of conception may help resolve these complications in few cases, but its success is unpredictable. What happens if the placenta separates or partially separates? If the placenta separates, it needs to be delivered, and any hemorrhage that occurs needs to be dealt with in the normal way. If the placenta partially separates, the separated portion or portions need to be delivered, and any hemorrhage that occurs needs to be dealt with in the normal way. Adherent portions can be left in place, but blood loss in such circumstances can be large and massive hemorrhage management needs to follow in a timely fashion. The diagnosis of placenta accreta is made only if the placenta fails to separate at delivery. Therefore, if it comes away, it is delivered as usual. If, however, it partially separates and partial accreta exists, the associated blood loss can be large. Adherent portions should be left attached as trying to separate them can cause severe bleeding. How is massive hemorrhage best managed? The surgical maneuvers required in the face of massive hemorrhage associated with placenta previa, cesarean sections should be performed by appropriately experienced surgeons. Calling for extra help early should be encouraged and not seen as losing face. Management of massive hemorrhage should occur in the normal way, including the use of utherotonic agents, which can be very helpful in reducing the blood loss associated with bleeding from the relatively atonic lower uterine segment. Advanced techniques may also be employed, and the use of bimanual compression or even aortic compression can buy time for extra help to arrive or for the anesthetist to catch up hemodynamically in the unstable woman. The most recent confidential inquiry into maternal and child health has reiterated the importance of considering calling in another senior colleague or colleagues with superior gynecological surgical skills early in the process. Specific techniques include uterine and vaginal packing with gauze, balloon tamponade, the B-Lynch suture, vertical compression sutures, and suturing an inverted lip of cervix over the bleeding placenta bed. Uterine and internal iliac artery ligation have been reported but make subsequent access for intervention radiology techniques and embolization extremely difficult or impossible. Follow-up of the woman after part or all of the placenta has been retained following placenta accreta. How should the woman be managed after placental retention? The woman should be warned of the risk of bleeding and infection post-operatively, and prophylactic antibiotics may be helpful in the immediate postpartum period to reduce this risk. Neither methotrexate nor arterial embolization reduces this risk, and neither is recommended routinely. Follow-up of the woman using ultrasound should supplement serum beta-human chorionic gonadotrophin measurements. Owing to the protracted nature of recovery, with complications occurring months after delivery, local arrangements need to be made to ensure regular review and, most importantly, ready access should the woman experience problems. Measuring serum beta-human chorionic gonadotrophin on a weekly basis to check it falls continuously can reassure to some extent, but low levels do not guarantee complete placental resolution, and so this should be supplemented by imaging. What chance of success can be quoted for a future pregnancy? There are insufficient data at present to make any firm prognosis about future pregnancy. Vasa Previa. Can we diagnose Vasa Previa clinically? In the antenatal period, in the absence of vaginal bleeding, there is no method to diagnose Vasa Previa clinically. In the intrapartum period, in the absence of vaginal bleeding, Vasa Previa can occasionally be diagnosed clinically by palpation of fetal vessels in the membranes at the time of vaginal examination. This can be confirmed by direct visualization using an amnioscope. Without access to the fetal membranes, it is not possible to diagnose the intact vessels of Vasa Previa clinically. Once the cervix has started to dilate, these vessels may be felt digitally during a vaginal examination. As the condition is rare, most clinicians will not be familiar with what they are feeling, and it is therefore important for clinicians to have a high index of suspicion if they feel something unusual and to confirm the diagnosis prior to membrane rupture if the consequences of fetal hemorrhage are to be avoided. Following delivery of the placenta, it is easy to confirm the presence of fetal vessels running through the membranes by simple clinical examination, but it is more difficult to diagnose Vasa Previa as the orientation of the vessels in relation to the internal cervical os and fetal presenting part in utero is not certain after delivery. In the presence of vaginal bleeding, especially associated with membrane rupture and fetal compromise, delivery should not be delayed to try and diagnose Vasa Previa. Because of the speed at which fetal exsanguination can occur and the high perinatal mortality rate associated with ruptured Vasa Previa, delivery should not be delayed while trying to confirm the diagnosis if fetal well-being is compromised. Can we differentiate between fetal and maternal bleeding? Various tests exist that can differentiate between fetal and maternal blood, but they are often not applicable in the clinical situation. The Clay-Hauer-Beck test and hemoglobin electrophoresis accurately identify fetal cells in the maternal circulation and fetal hemoglobin. Both can detect the presence of fetal hemoglobin in concentrations as low as 0.01%, and both can be used to identify fetal cells in vaginal blood loss. The disadvantage of both of these is that they are laboratory-based tests that take a significant amount of time before a result is obtained, thus rendering them of little use in this clinical situation. The resistance of fetal hemoglobin to denaturation with alkali has been used by various methods to identify fetal bleeding. The first of this was the AP test, but this requires the presence of at least 60% fetal hemoglobin to be positive and requires centrifugation. Can Vasa Previa be diagnosed using ultrasound? Vasa Previa can be accurately diagnosed with color Doppler ultrasound, often utilizing the transvaginal route. The ultrasound appearance of Vasa Previa is of linear echolucent structures overlying the cervix. Ultrasound diagnosis of Vasa Previa is not without difficulty, and factors such as maternal obesity, scarring, and fetal position can influence accuracy, and care must be taken not to mistake cord presentation for Vasa Previa. Should we screen for Vasa Previa? At present, Vasa Previa should not be screened for routinely at the time of the mid-trimester anomaly scan, as it does not fulfill the criteria for a screening program. How should Vasa Previa be managed? In the presence of bleeding Vasa Previa, delivery should be achieved by Category 1 emergency cesarean section. Fetal well-being should be confirmed at the time of any antepartum or intrapartum hemorrhage, and this is currently best achieved using the cardiotachograph. If signs of acute fetal compromise are present, delivery should be achieved as soon as possible, usually by Category 1 cesarean section, to minimize the risk of fetal exsanguination. In cases of suspected Vasa Previa, transvaginal color Doppler ultrasonography should be carried out to confirm the diagnosis. If there is either an ultrasound or clinical suspicion of Vasa Previa in the absence of fetal compromise, a formal systematic assessment of the region of the internal cervical os should be undertaken using transvaginal color Doppler ultrasound. In confirmed cases of Vasa Previa at term, delivery should be carried out by elective cesarean section in a timely manner. In view of the risk of fetal hemorrhage with the onset of labor or membrane rupture and the minimal risk of neonatal lung disease, once Vasa Previa has been confirmed at term, delivery should be carried out by elective cesarean section as soon as is practicable. In cases of Vasa Previa identified in the second trimester, imaging should be repeated in the third trimester to confirm persistence. As gestation advances, Vasa Previa can resolve in up to 15% of cases. To avoid unnecessary anxiety, admissions, prematurity, and cesarean sections, it is essential to confirm persistence of Vasa Previa in the third trimester. In cases of confirmed Vasa Previa in the third trimester, antenatal admission from 28 to 32 weeks of gestation to a unit with appropriate neonatal facilities will facilitate quicker intervention in the event of bleeding or labor. In view of the increased risk of preterm delivery, administration of corticosteroids for fetal lung maturity should be considered. In the presence of confirmed Vasa Previa, elective cesarean section should be carried out prior to the onset of labor. Elective cesarean section should be between 35 and 37 weeks of gestation when the risk of prematurity have significantly decreased. Laser ablation in utero may have a role in the treatment of Vasa Previa. . Clinical governance. Debriefing. Postnatal follow-up should include debriefing with an explanation of what happened, why it happened, and any implications for future pregnancy or fertility. Training. All staff should receive local training for obstetric emergencies, which should include massive hemorrhage and acute fetal compromise. Clinical incident reporting. Clinical incident forms should be completed for all adverse events. In the context of this guideline, this would include all cases of massive hemorrhage, any peripartum hysterectomy, any case of ruptured Vasa Previa, and any unexpected admission to the neonatal intensive care unit.